Well, today's guest is Dr. Ben Malcolm, who is the Assistant Professor of Pharmacy in Western University of Health Sciences. He's also a board-certified psychiatric pharmacist and a registered pharmacist. Dr. Malcolm, welcome to the show.
Thank you so much for having me. It's great to be here.
So you have a fascinating background. I didn't realize you can get board certification in psychiatric pharmacy.
Yeah, actually, that's one thing about pharmacy in general is not a lot of people know is typically when they think of a pharmacist, they think of someone that just kind of counts pills or dispenses a medication. But pharmacists in general have been assuming more clinical roles for decades, really, and they have all sorts of different board certifications that you can obtain, similar to what you would for physician specialties as far as things like infectious disease or ambulatory care, critical care medicine. But I've obtained board certification in psychiatric pharmacy because it's absolutely the most interesting area to me.
Yeah, fantastic. And it looks like you have been able to study psychedelic substances. Tell us a little bit more about how you became interested and how that started for you.
Yeah, so it really began as a kind of an intellectual curiosity, I would say, when I was a teenager. And at the time, I was watching television shows, and particularly one show called Intervention that was about addiction and addictive substances. And in this program, they would invariably document somebody that was using some type of substance in a very addictive and chaotic, destructive type of pattern. And they would kind of corner them and say, you have to go to rehab or quit, or we're going to cut you off. And looking back, it's an absolutely horrible model of treating addiction, but it served to kind of spark my curiosity as far as, why is it that some drugs like opiates or heroin can be so sedating to the point that you actually stop breathing or pass out and die of respiratory depression, whereas other drugs like cocaine or methamphetamine leave you extremely stimulated and you'll be up all night, yet they kind of converge in their tendency to cause addiction and similar sorts of patterns of use and craving. And, this led me to just start searching on the internet for different drugs of abuse. And through this process, I found a website called Erowid.org. And Erowid is a website that's a repository of anecdotes of all sorts of different substances. And that's where I really first heard about and started reading about substances like MDMA, psilocybin, mescaline, LSD, and others. And kind of what I noticed is that, with those, initial substances that I mentioned, things like heroin and cocaine, methamphetamine, the story was almost invariably one of self-ruin. Whereas the psychedelics, it seemed that, most of the time the person was endorsing an incredible and amazing experience. And, even when they weren't endorsing it to be incredible, they were, saying things that, well, when I woke up the next day, I actually felt less anxiety or more comfortable in my own skin than I ever had before. And this just kind of, made it very clear to me as a teenager that there was something going on with the regulation of drugs that was off, that was wrong, in that, it seemed that there were just, hundreds of these different anecdotes of people essentially stating that they were helped by these substances and didn't wake up and want to use again or find themselves using larger and larger amounts to try to achieve the same state that they were, had previously achieved. And I would say that this really kind of set me off on my entire educational path. It was because of this curiosity as a teenager that I studied pharmacology at UC Santa Barbara. And it was, that education that essentially led me to decide to go to pharmacy school. And, throughout this entire educational adventure or journey was always the psychoactive substances that I had found to be the most fascinating, and it kind of made sense that at the conclusion of the educational journey and at the end of the day that my current career is focused still on those substances that piqued my interest initially.
Interesting. And you have been able to study these substances more in depth as a pharmacist, correct?
Yeah. So as a pharmacist, and I'm an academic pharmacist, so research is part of my position, as well as teaching and clinical practice. But yeah, I have had the fortune of being able to get a hold of particularly one data set from Ibogaine Clinic in Mexico. Had the opportunity to also get some data from Ketamine Clinic. And then I've also just really avidly devoured all psychedelic literature that I can find, especially the kind of clinical data that's been coming out in the last 15 years or so.
Mm-hmm.
And yeah, as a person that's involved in higher education, the training of our kind of next generation of pharmacy professionals, I feel that it's incredibly important to have somebody that's kind of synthesizing literature and preparing for the next generation of pharmacists for this new paradigm of psychedelic therapy that's just around the corner.
Fascinating. So I heard an amazing lecture by you regarding psychotropics versus psychedelics in treating a variety of different conditions. Obviously, you're highly qualified to speak on both. So can you run through a synopsis? Perhaps we should define what psychotropics are for the audience as well.
Yeah, so a synopsis of what psychotropics are, and then what kind of I'm sorry, what's this question?
So I guess we should probably tease out disease state by disease state, but how psychotropics compare to psychedelics in treating a variety of conditions such as pain, depression, etc.
Sure. Yeah, I would say that like psychotropic, I mean, as a word, tropism or tropic just means to turn towards or move towards. And there's all sorts of different types of tropic things out there. Phototropism, for example, if you have a house plant, you'll notice that it tends to turn towards the window or turn towards the light. So psychotropic just means the use of a medication to kind of subtly influence or change the direction of something, towards where you're hoping it will go. And in the case of, mental illness, it's we're hoping that people become less symptomatic, less dysfunctional, happier, more functional, things like that. I would say it's an imperfect rule, but does a decent job generally as far as if you divide psychotropics, the ones that are FDA approved today, and psychedelics, you'll kind of notice that for the most part, psychotropics are geared towards reduction of symptoms and making a person more functional. And they do this by typically increasing your tolerance to stress, and it's kind of specifically the antidepressants I'm talking about, but you could make this case for other psychotropics as well. So they kind of help you to tolerate a difficult situation or maybe kind of increase your resilience, but they don't necessarily inspire you to change your situation so much. Mm-hmm. Psychedelics, on the other hand, tend to be agitators of the mind. They tend to bring up repressed emotions. They can also do very special things as far as eliciting spiritual experiences. And it seems that psychedelics, when they're used in large doses and kind of combined with psychotherapies, tend to allow the person to really bring up what is a big roadblock for them and kind of process it or work through it. And this is oftentimes coupled with this sort of spiritual experience that creates a cathartic release of whatever type of problem that they have been holding on to that's causing their disturbance. And oftentimes there's, just massive lessons in forgiveness, empathy, self-love, experiences of connectedness. And although psychedelics are highly variable in the types of phenomena that people can experience, some of these lessons that I just mentioned really become thematic in psychedelic healing experiences.
Interesting. Now,
so I guess, I guess maybe to finish that thought and wrap it up, I guess I would just say that generally the traditional psychotropics are the goal is symptom management and increased functionality by tolerating a difficult situation, whereas it seems the goal of psychedelics are essentially to bring up and move past whatever has been kind of holding you back, and at the very least, greatly reduce your symptoms and make you more functional. But I think really the end goal of psychedelic therapy is to resolve the problem.
Okay, fantastic. That was a great synopsis. Now, let's get into the weeds a little bit. What divisions of psychotropic medications are out there that are being currently used in clinical practice? What are some of the major classes you might see?
Yeah, so I would say, maybe to answer this question, we'll kind of talk about what psychedelics are being studied for, and then what they're really not being studied for. So psychedelics at the moment are being studied for mood disorders like depression and anxiety, other disorders like obsessive-compulsive disorder, trauma-based disorders, particularly post-traumatic stress disorder. And I would add to that all of the others that I mentioned, depression, anxiety, OCD, oftentimes have a traumatic etiology or traumatic root to them, even if the illness is not necessarily called a trauma type of disorder, as well as substance use disorders or addictions. What psychedelics are really not being studied for are bipolar disorders and psychotic disorders like schizophrenia. So when it comes to thinking about medications, the antidepressants, the benzodiazepines, the psychostimulants, these are the types of medications that you're more likely to see being used in somebody that's treated with depression, anxiety, obsessive-compulsive disorders, right? Whereas things like the antipsychotics are perhaps more indicative that there could be some type of underlying psychotic condition or a bipolar disorder. And this type of reverse engineering between medication regimens and psychiatric diagnoses is flawed for a number of reasons. Generally, it does an okay job, but there's all sorts of off-label medication use, and even the antipsychotics now are used off-label in low doses for things like insomnia or as adjuncts to antidepressants for mood disorders. So just by virtue of taking an antipsychotic, it doesn't mean that you are psychotic, and it doesn't mean that you're the worst candidate for psychedelic therapy. But particularly when I see high doses of mood stabilizers or antipsychotics, I tend to think that person is probably not a good candidate and would probably be contraindicated to be using psychedelics for a healing purpose.
Interesting. So while we're on that particular subject, in terms of the populations that should really avoid using psychedelics for any number of reasons, people with a history of psychosis, obviously, or a family history would definitely fall into that category, correct?
Yeah, and I mean, I think that this is, where you probably just want an expert evaluation, because these things come in shades of gray. Oftentimes, I mean, there's bipolar 1 disorder that's characterized by kind of true mania and usually requires hospitalization when mania occurs. There's bipolar 2 disorders, which the person never actually gets floridly manic. Maybe there's an episode of hypomania, but it's characterized by a real stubborn and deep type of depression. As far as psychotic disorders, there's truly what we think of as organic brain disease, like schizophrenia, and then there's people that you'll meet that perhaps had an issue smoking too much methamphetamine one weekend, and that led them to be paranoid, and they went to a mental hospital, but it's been 10 years and nothing like that ever recurred again, and it was purely in the context of using stimulant drugs that kind of led them to the psychosis. So I guess what I'm saying here is that oftentimes these labels are kind of tossed around, and just a label of a bipolar disorder in of itself, is probably a good clue that the person may be contraindicated to use, but it should not be the kind of say-all, end-all, be-all decision-making that because, someone somewhere along the line used this label that they're forever excluded for using psychedelics. And my personal approach is to kind of walk through their history of mental health symptoms as well as treatments, and kind of go from there as far as trying to decide what level of risk the person would be as far as taking on a psychedelic experience.
So what kind of expert would people be able to turn to in order to do that evaluation? Because I think many candidates would be afraid to talk to their primary care physician because primary care physician is either not familiar or not comfortable with these class of medications.
So I think you've really kind of, put your finger on the pulse of a large problem that is, I think relevant clinically now, because we have so many people that have read Michael Pollan's novel or otherwise become savvy to the healing potential of psychedelics, even in kind of an illicit drug environment. But if they were approved, you have millions upon millions of people that are struggling with depression, anxiety, that are using SSRIs, that are potentially candidates and may want to do this. Yet very, very few people that are adequately qualified to really have this type of discussion about whether they should use it, what kind of person would be contraindicated. So there are some resources at present, and certainly there are kind of a group of psychotherapists or psychedelic integration coaches, functional and integrative psychiatrists, as well as other healthcare professionals like myself that, are doing this work at the moment. However, where can the person go to just find this information out in a quick and simple type of way? I'm not really sure. That's exactly the type of resources that I'm interested in creating for people, because it's sorely needed. And if MDMA, psilocybin, ayahuasca, if they all get legalized in the next 10 years, that's not going to change the fact that we have 50 years of healthcare providers that have only known these things as demonized drugs of abuse, and have, inadequate knowledge to really talk with people about the risks and benefits of using them in a balanced way.
If people go to your website, would they be able to find more resources?
Yeah, so on my website, I have consulting services where if you really want to talk with me one-on-one, we can do that. I have drug information requests. So this is, if you want to just generally know a piece of information about drugs and a written answer is preferred, that's a service as well. I also have a number of blogs and I've really been doing this blogging thing for about the last 6 months, and boy, is it hard to write a monthly blog when you're trying to deliver high-level information, and you're an assistant professor, and you're a husband and father, and so I have not been able to keep up with my monthly schedule, but I do have several articles now, one with psychedelics and antidepressants, one with psychedelics and benzodiazepines, one with psychedelics and stimulants, as well as a couple others that kind of start dealing with, right, I'm on these medications, they are not working for me or not working as well as I would like them to. I'm hearing about this seemingly miraculous potential of psychedelic healing. I want to give it a try. How do I get there? You know, what kind of process would I need to go through? Do I need to stop these medications? Do they interact with psychedelics? Are they compatible? So I'm trying to write these blogs for different people to be able to come and read them and get an idea of how feasible it would be for them to use whatever psychedelic with whatever psychotropic medications that they're taking at the moment. And hopefully before the new year, but I have a couple more, one on pain and one on antipsychotics that are in the works.
That's great. Now, we'll put your website in the show notes for people to access as well. Could you tell them the address in case they're listening and they want to look up right now?
Yeah, it's spiritpharmacist.com.
Perfect. Fantastic. So I know that was a nice segue, but we were talking about essentially the different classes of psychotropic agents. And you were talking about antidepressants, benzodiazepines, etc. Can we delve into, I guess, class by class, antidepressant class?
Delve into them in regard to their compatibility with psychedelics?
Yes, and maybe also really describe what the class does. So there's SNRIs, SSRIs, maybe some examples of those agents. So people, at least if they are on those medications, they can recognize and they can understand what they're taking, and then how they can potentially, either if they want to wean off, they can potentially do that, etc.
Yeah, so as far as let's start with antidepressants. And I think that antidepressants are kind of like the flagship class to pay attention to in this space, because if you go to psychiatric prescribing guidelines as they are right now, whether it's depression, anxiety, PTSD, or OCD, the first line drugs are all SSRI or SNRI antidepressants. And these are all the illnesses that psychedelics are being studied for. So it seems to me that this class of drugs is probably number one as far as the class that people have the most questions about when it comes to compatibility with psychedelics. And to back up a little bit, SSRI means selective serotonin reuptake inhibitor. SNRI means serotonin norepinephrine reuptake inhibitor. They're very, very similar classes of medication, and what they do is increase serotonin and potentially norepinephrine in the synapse or space between neurons. And this does not instantly lead to any type of appreciable boost in mood or decrease in anxiety. Instead, you actually have to wait 4 to 6 weeks with these medications. So it seems that there's some type of neuroadaptation event that occurs over a period of weeks in response to increased serotonin in your synapse that tends to allow you to tolerate stress a little better. This helps with anxiety. It also helps with depression or low mood. These antidepressants are not perfect drugs. Probably 50% of people get some kind of response to them initially. So probably 50% of people don't really get an initial response. And even with trying several different types of antidepressants, there's a solid probably 20-30% of people that seem to not really respond to any of them. So this is a group of people that we would label as treatment resistant or having kind of treatment resistant depression. And this is kind of what psychedelics are being studied for, is this group of people that standard antidepressants have not worked well or really at all for them. Some drugs in this class, the SSRIs, are your Prozac or fluoxetine, your Zoloft or sertraline, Lexapro, escitalopram, Celexa, citalopram, Paxil, or paroxetine are probably the big ones. You have a couple of new ones that have come to the market recently, Trintellix, which is vortioxetine, as well as Vibrid or Vilazodone. And as far as the SNRIs, you have Effexor or venlafaxine, as well as Cymbalta or duloxetine. And as far as how these medications mix with psychedelics, it really depends on the psychedelic. So MDMA, I'm sorry, but the SSRIs completely abolish MDMA experiences. There's been several human studies, actually, that have demonstrated this, so this is not anecdotal data. We can hang our hat on that and know that if you're taking an antidepressant, MDMA is very unlikely to deliver the type of subjective experience that is now being shown to have incredible healing potential for PTSD. When it comes to antidepressants and things like tryptamine, so psilocybin or LSD, it's sort of a mixed bag. So there are stories out there or anecdotes of people that have blunted or diminished experiences. There are stories out there of people that have had full-blown mystical experiences with incredible healing effects on their antidepressant while taking psilocybin. So that one is just sort of unclear, and there are studies planned that will kind of formally address the potential for drug interaction a little bit more. So with those two, the MDMA as well as the tryptamines like LSD, psilocybin, it does not seem that there's a risk of severe physical toxicity like serotonin syndrome when you combine them.
Oh, interesting.
But there is this risk of blunted or kind of diminished experiences. And again, it's much better demonstrated with MDMA than psilocybin or LSD at this point. Do you want me to keep going?
Well, question about that. So MDMA,
yeah.
Obviously, along with antidepressants, you will not have the MDMA experience, and it sounds like it's not dangerous and it's not fatal.
Correct. So it's not dangerous to combine antidepressants with MDMA, but it's also not really worth your time because there's very little subjective experience that's going to occur.
Got it.
The psilocybin and LSD, same story as far as the danger of physical toxicity. There's not really any. There's literally zero data demonstrating that it's risky, and the fact that they're planning clinical studies to address this kind of makes you pretty confident that it's not risky, because they would not approve a clinical study in human beings if there was this real risk of serotonin syndrome. Speaking of those severe physical toxicities, though, in serotonin syndrome, I think it's pretty critical to mention that with ayahuasca, there is this risk of serotonin toxicity or serotonin syndrome if it were to be combined with antidepressants like the SSRIs or SNRIs. And oftentimes, reading on internet forums, these drug interactions are frequently conflated, is that you'll people saying that psilocybin and antidepressants will give you serotonin syndrome. That's false. But when it comes to ayahuasca, yes, there is real risk of serious or life-threatening physical toxicities, particularly with the antidepressants.
Now, since we are talking about ayahuasca, there's been some deaths that have been reported in the media in association with ayahuasca usage. Is that because the person was potentially taking SSRIs at the same time, or what other mechanism of action can endanger a person's life while going through the ayahuasca experience?
Yeah, so ayahuasca actually, in of itself, is a pretty safe medicine, and they've done estimates of what the lethal dose of ayahuasca would be, and it's essentially about 20 cups of ayahuasca. And the thing about it is that ayahuasca, compared to other psychedelics, is an incredibly physically intense medicine, and it's a purgative, meaning that most people that drink ayahuasca actually vomit, more than 50% of them. So when you kind of think about, could you just simply overdose on ayahuasca? I mean, I guess it's possible to drink 20 cups, but honestly, the propensity of ayahuasca to make you vomit makes me very skeptical that anyone could actually drink that much and hold it in their stomach for long enough for all of it to be absorbed and really find themselves in the place of dying purely from an ayahuasca toxicity. Now, when it comes to mixing it with other medicines, yes, that can make the risk go up exponentially pretty quickly. So the antidepressants I mentioned, others that I would, say are contraindicated with ayahuasca would be psychostimulants like your Adderall, amphetamines, Ritalin, or methylphenidate. There's some in the kind of cough and cold section, as well as kind of weight loss supplements. But again, the kind of big theme here is that they all block serotonin reuptake or release serotonin, or are some type of stimulant that releases other neurotransmitters. So that's kind of like one way you can get in hot water with ayahuasca. I would say the other way is that because it is physically purgative, and ayahuasca, when it's used, is oftentimes used several evenings in a row. There's retreat centers in South America that kind of, maybe you'll go for a week or 10 days and imbibe or drink ayahuasca 4 or 5 times in that 10 days. And oftentimes they're offering other things at the same time. Tobacco is another hugely healing medicine that's utilized in the Amazon via a variety of routes of administration. It seems like the rapé snuffs in conjunction with ayahuasca can be helpful, healing, not much risk of toxicity there. But there have been a couple reports of people that are using tobacco more systemically. For example, there was one person that died during an ayahuasca retreat after they had received a tobacco enema. Wow. So it kind of seems that, one other mechanism that we should probably be aware of is stacking purgatives. So if you're, going to be using something that makes you vomit with other things that make you vomit, and you're doing that for day after day on end, and you're not repleting yourself with adequate fluids and or electrolytes like salt. And that's actually part of it too, is that a lot of these retreat center diets and part of traditional dieting for ayahuasca actually involves a fairly bland diet that is almost devoid of salt. So I think that there has just been certain circumstances where people are stacking purgatives and really not listening or taking care of their body at the same time, that has unfortunately led to some type of arrhythmia or seizure, probably due to not having any electrolytes.
Interesting. What is is there a prevalence that's been reported in terms of how dangerous it could be?
It's very difficult to estimate a prevalence because ayahuasca is used in a very secretive and clandestine type of way. So, we have no clue how many ayahuasca ceremonies really are taking place. But it does seem to be a pretty rare occasion that, people are, actually hurt, hospitalized, or end up dying. There was one case series of ayahuasca calls to poison control centers, and there were quite a few incidents that seemed fairly severe. This was, I think, over around a 10-year period, and I think there was something like 500 and something calls total, but maybe only 20 or 30 of them were actually, severe toxicities. I think the rest of it was probably someone showing up to the emergency department with a panic attack that had drank ayahuasca, and the emergency department doctor, never heard of it. So what are you going to do? You're going to call poison control and ask them or / report it. So it does seem possible, but, you kind of think about the numbers here. It's sort of like, okay, so maybe there's 30, 40 cases of severe toxicity that have occurred over a period of 10 years. Again, I have no clue how many people are drinking ayahuasca, but I'm going to guess it's in the tens of thousands,
Right.
if not millions of people. And with these poison control calls, too, there's really no information about, was this person drinking at a ritual ceremony? Was this person on any contraindicating medicines? Or was this, a case of a person ordering the plants off the internet, brewing it themselves, and then trying it out at home with whatever medications that they were taking concurrently? So I think that even looking at these severe poison control cases where, it really does seem that something severe and unfortunate occurred, it still doesn't make me want to conclude that ayahuasca is incredibly dangerous, and it actually just makes me want to advocate more for, safe use of ayahuasca, because, again, overall, it actually is a very safe medicine physically, and, it just boils down to being able to coordinate educational messages across healthcare providers and government entities, which of course we're unable to do in an environment of prohibition.
Interesting. Now, are there any clinical studies done? And right now we've talked about psilocybin and ayahuasca, but are there any head-to-head clinical trials done in terms of evaluating a person's depressive symptoms on a psychedelic versus an antidepressant, for example?
So there's nothing that they've done that's truly head-to-head. They have done some kind of theoretical comparisons, or let's look at, these studies over here that dealt with antidepressants and these studies over here that dealt with psychedelics. And when you kind of look at those more indirect type of comparisons, what you see is that the antidepressants work, but they work to a sort of minimum degree. There's this thing in statistics called effect size, and it's essentially a measure of how big was the effect that you observed. And for antidepressants, the effect size is small. Mm-hmm. For psychedelics, the effect size is large. It's like almost off the charts large. Like I don't think psychiatry has ever seen an effect size this large.
Wow.
It's early days for our research. I mean, we have so many studies now that have demonstrated psychedelics are helpful. I think it's pretty hard to refute that there's a signal for healing there. But, can you compare 5 or 6 phase 2 studies of MDMA-assisted psychotherapy and PTSD to, a couple dozen trials of antidepressants with hundreds of people in them? Yeah, I mean, I think I would like to wait for the phase 3 trials and probably post-marketing surveillance to really, truly understand, like, what is the, oh man, it makes it seem like I'm not into psychedelics. Totally am. And I think that they probably are superior to the antidepressants. I just don't think we have the head-to-head data to kind of absolutely say that quite yet. And quite frankly, drugs, whether they're antidepressants or psychedelics, always work better in clinical trial environments than they do in real life. Mm-hmm. There's something about the kind of perfect experimental setting of a clinical trial that tends to make the effects larger and the side effects or propensity for things going wrong less. Mm-hmm. So again, you compare, antidepressants that are used in all sorts of wacky ways in society for the last 30 years compared to, this, teaser of, what psychedelics are truly capable of in like a phase 2 study with 20 people in it. It's just, it's not a direct comparison. Right. I mean, you look at them side by side and it's like, yeah, psychedelics are blowing antidepressants out of the water, but I guess what I'm trying to say is that there's all sorts of things that, you may want to take into account
Mm-hmm.
that are unaccounted for in this indirect comparison.
Got it. Now, with ayahuasca, it looked like we were kind of focusing on depression right now. With ayahuasca, I heard that it could make the experience afterwards much better, or the person can become significantly more depressed. Is that true?
So there's, by and large, I would say that like ayahuasca tends to decrease people's symptoms.
Mm-hmm.
That is, much more common than the story of my symptoms worsened after using ayahuasca. But those stories are out there, and I believe they're true. I mean, I don't think anyone has any incentive to go to an ayahuasca ceremony and then just make up that they got more depressed afterwards.
Mm-hmm.
So, I have to believe that there's some truth to it. I think that if you're kind of looking at just purely a biological lens, I don't know if we're going to really have a great answer to why that occurs. I think that, part of this is looking at drugs through a more spiritual or psychospiritual type of lens. And, why is it? We kind of think like what comes up in if you take a psychedelic and you experience a lot of anxiety, if you experience a lot of anger, if you experience a lot of sadness, if you experience a lot of joy, ecstasy, and bliss, there's a reason is essentially the thinking in psychedelic work or psychedelic therapy is there's a reason that this anger is coming up for you in this experience. There's a reason that this anxiety is coming up for you. So, post ayahuasca depression, I think, this is where the role of integration specialists, whether they be therapists or integration coaches, can be very, very valuable, because I personally feel that maybe there's something about this sudden change in mood post ayahuasca that is a big clue for the person.
Mm-hmm.
Maybe something happened in the experience itself that was kind of traumatizing and left the person feeling kind of depressed.
Right.
Maybe ayahuasca, they went to the jungle and had this incredibly insightful type of experience, but then they went back to their hometown where everything was exactly the same and made no changes as a result from their insight, and essentially wound up feeling extremely depressed. So it's that's the thing with psychedelics. Again, they agitate the mind and they bring stuff up. So unless you are ready to act upon what they bring up, then you probably shouldn't be asking what they can bring up for you, because you just don't know what's going to come. And I think by and large, for most people, what comes is their demons. It comes out of them. They process it. They heal it. They feel much better. For some people, for some reason, it doesn't quite come out of them, or they get a little bit stuck, or something happens in the experience itself that wigs them out and spooks them and makes them feel very different afterwards. It's difficult to say, oh gosh, biologically, I don't really have a great explanation why it would make some people sad and some people not. And I guess it's not that much different than the standard antidepressants, really, is that, some people feel that the emotional tolerance that they provide is healing and therapeutic for them. Some people claim that turns them into an emotional zombie that was devoid of all feelings, and they absolutely hate it. It's just a little bit of individual neurochemistry, a little bit of psychospiritual journey, and that's what I have to say about that.
Interesting. Do you foresee a time where psychedelics can replace psychotropics, or maybe antidepressants in particular?
Yeah, so replace, yes, I think that they can replace them as first-line agents. So again, like all the psychiatric prescribing guidelines, depression, anxiety, PTSD, OCD, it's SSRIs or SNRI, antidepressants, first line for absolutely everything.
Right.
I think that 10, 15 years down the road, we're going to have enough data from psychedelic studies to seriously challenge whether SSRI should be first line. And I actually think we have enough data to seriously challenge it right now, but the medicine is extremely slow to change their status quo. It's a very slow-moving thing. It does not uptake technology incredibly quickly. Most hospitals are operating on 20-year outdated computer systems and things like this. For this reason, is upgrading the infrastructure is difficult to do, and blah blah blah. But I think that, to me, it's not about replacing per se. I think that psychedelics could replace SSRIs or antidepressants as the first-line therapies, but I just think that there's a more nuanced way of approaching and treating mental illness, and I just think that there's room in the world for everything, that there is a place for these antidepressants, and perhaps I'll give you an example is that, I've worked with some clients, and we have maybe client A who is traumatized from a relationship where their partner has been cheating on them, and they are still with that partner, and they are completely codependent. They're unable to leave that partner, maybe because of financial reasons, health insurance, whatever it is, living situation, a house, I would have nowhere to live without this person, et cetera, et cetera. And they're using psychedelics to get over the trauma. But they're still living with that person, and that person is still cheating on them. So, that seems like, gosh, unless you're truly ready to leave that situation, however hard it is and whatever it might bring up, actually the right approach might be to tolerate something difficult. It might be a standard psychotropic.
Oh, interesting.
Whereas, let's just take the same scenario, and now the person is like, oh, well, I was taking these antidepressants because I was going through a brutal divorce. We're fighting over our kids. It was wrecking me emotionally. I just had to get through it. That's 2 or 3 years behind me now. I'm feeling a little bit better. I still kind of struggle in finding who I am without my, partner. Now that I'm kind of on my own again, maybe for the first time in a long time, I'm trying to construct a new identity for myself. Yeah, this is exactly where psychedelics can be helpful as far as, helping a person move on to find a new identity for themselves. Essentially, the person that just got out of the divorce is ready and willing to do anything to change their situation, anything that the medicine tells them to, anything that comes up as far as their intuition, they're ready to act on, whereas the other person is very, very stuck in their situation. And okay, maybe a psychedelic would loosen that up, and maybe it would allow them to see their situation in a new light, and maybe plan an exit strategy that they hadn't really thought of before, or give them the courage to leave. Or maybe it wouldn't, and it would essentially exacerbate the problem because it really just brought up all of their trauma, but they're not in a situation or a place that they can able to move past it. So yes, I do think that psychedelics are probably more effective than the standard antidepressants, and yes, I do anticipate that we're going to see major changes in the way that we approach mental illnesses with the approval of these things, but, will they ever just truly replace it and, there's no more role for standard psychotropics? I don't really see that either.
It's very interesting. I definitely like the fact that you kind of highlighted situations where one agent might be more effective than the other. And I've actually witnessed it firsthand, where I've had friends that are in difficult situations and they're on antidepressants, and they're tolerating a situation that they should potentially be walking away from. But it's just kind of interesting. I think it's important to be aware, if you are taking those agents, that you might be tolerating something that you should potentially not be tolerating. So
yeah, and I like that you brought this up, is that the kind of almost reverse situation could be true as well, is that you are actually ready to move past your situation, but you're taking drugs that are inhibiting you from moving past your situation. And this is probably where psychotropics tend to, hold people back as far as their growth, their healing, and their progression on a spiritual path.
Interesting. Now, do you find that with the use of psychotropics, is there any long-term effects on the production of serotonin or norepinephrine, or is there any rewiring in the brain at all that's been hypothesized?
Yeah, so as far as okay, you're on an antidepressant and now you're not on an antidepressant, is there any, data that shows that it kind of irreparably damages your brain? Not that I'm aware of, but we absolutely know these drugs change your brain. I mean, like I said, you take an antidepressant, boost serotonin. It's not until 4 to 6 weeks of taking that you start to feel better. So absolutely, there has to be some type of neuroadaptation event that's occurring when you start taking it for the drug to work. And, I would presume and think that it is supported by data that there is also a neuroadaptation event that occurs when you stop the drug. Because, we know that antidepressants have physical withdrawal syndromes. Oftentimes, the drug is completely eliminated from your body within, 3, 4, 5, maybe 7 or 8 days, yet the withdrawal syndrome persists for weeks, a month. I've met people that are struggling with withdrawal for 6 months or longer. So it seems that, yes, these drugs do disturb the body's normal homeostasis. That's their intention, is because the person wasn't feeling very good, and we're hoping that, we can use a psychotropic to make them feel better. But, if it doesn't work out, the person is essentially left not feeling better with a disrupted homeostasis. And this is not just psychotropics that do this. You could make the same sorts of arguments around psychedelics, and that's exactly the types of arguments that we are making, is that, yes, they impact the default mode network and they put you in a neuroplastic state. And this is hugely beneficial for a healing effect to occur. Essentially, they're kind of oh, psychedelic changes you forever. That was kind of the narrative as far as it being a bad drug. And, we're kind of flipping the script and saying well, yeah, that's what we're hoping for. We're hoping that, unquenchable thirst for alcohol is quenched. We're hoping it's changed forever. We're not hoping that, you just take it and you're exactly the same as you were before. That's the point of using either psychotropics or psychedelics, is that you're wanted to change you. Right. But change you for the better, right. Obviously. Yeah.
So the withdrawal symptoms that you said may persist for some people for a few months. Is there any recommendation for that class or that population?
There really isn't. And I have just scoured the literature on several occasions to try to find something that would help SSRI withdrawal, and I have not really found much that's supported by data. I've consulted with, as well as read in several forums of people microdosing to help with their antidepressant withdrawal symptoms. Some people seem to think it's helpful, others don't. There is kind of this herbal SSRI called Canna out there that I have not had much experience with, but given that it blocks the serotonin reuptake pump, and that's why I believe people are having withdrawal symptoms, is they're essentially missing that blockade or feeling very low because they have, less serotonin than normal. That could be helpful. People get really obsessed with 5-HTP or L-tryptophan as far as supplements for depression. And, these supplements help your depression when you are tryptamine depleted, but people that are in SSRI withdrawal are not necessarily tryptamine depleted, and most people actually have adequate amounts of L-tryptophan in their diet. So, you'll meet a lot of people that swear up and down by it, and hey, I ain't stopping them. Like, if it works for them, great. But from my understanding of those supplements, that they probably wouldn't be so helpful. And I've had some people that feel like it actually kind of exacerbates things, kind of a mixed bag. There's all sorts of other things out there. Fish oil, EPA, DHA tends to be mood uplifting, help with anxiety. Selexin or Calm Aid is a lavender oil supplement by mouth, helpful for generalized anxiety disorders. Things like turmeric or anti-inflammatory types of compounds tend to be helpful. There's St. John's wort. That's helpful for depression, but probably comes with its own set of interactions and problems if you're going to plan on using a psychedelic. So there's all of these kind of things out there, and some of them, do work on serotonin and seem to me more likely to have an effect. Others, work on other things and, maybe help boost your mood or anxiety in some other way. So I think that the kind of question becomes like, okay, what are you experiencing in those months after you stop your antidepressant? Is it withdrawal or is it return of your symptoms? If it's withdrawal, I'm sorry, I don't really have very much for that. There's just very little data about anything that's helpful for that situation. But if it's return of your symptoms, all right, well, yeah, there's plenty of things that could be helpful for that. And, kind of teasing out which one is more likely, and maybe it's kind of both, especially in the first few weeks to a month afterwards. But once it's been 3-4 months, you kind of have to start suspecting, well, this is probably a return of illness rather than just like a withdrawal syndrome that never ends.
Right. And I heard the 90-day mark to be important. I know some psychiatrists say that's when they really fully realize if the person can be off of antidepressants or not.
Yeah, that sounds about right. Is that, usually the withdrawal syndrome is supposed to peak within about 2 weeks. It's supposed to be mostly over by about a month. So yeah, if it's really been 3 months and, you're kind of like, oh, I'm still in withdrawal. Yeah, I kind of feel like the psychiatrist has a point that, at that point, the chances of it being withdrawal are lower and the chances of it being your illness is higher.
Right. Makes sense. Do you see similar withdrawal patterns with psychedelics?
No. I mean, psychedelics don't cause a physical dependence, and they lead to such a rapid tolerance that if you try to use them day after day, they result in markedly diminished experience. So it's a very atypical use pattern, like first and foremost, that someone would be using a psychedelic every day. But there are, plenty of old school psychonauts that tried to take acid every day in the 60s for a while, and they didn't have any type of withdrawal syndrome that's associated with that. So no, psychedelics don't have a withdrawal syndrome. They're also not addictive substances, despite them causing that rapid physical tolerance that I just mentioned.
Interesting.
I guess to back up, when I say not addictive, I would put things like ayahuasca. I put the tryptamines, really, psilocybin, LSD, ayahuasca, 5-MeO-DMT. I would put them in the totally non-addictive category. Things like MDMA, they call it ecstasy for a reason. It typically is a very euphoric type of experience, and it would be very, very rare for someone to get into an addictive use pattern that they are using MDMA every single day. But it's not that uncommon for people to get into a pattern where they use large doses of MDMA every single weekend, spend, Monday, Tuesday, Wednesday kind of recovering, and then, Thursday, Friday is like gearing up to do it again. And, they could do this for a period of months, but it almost always ends in some type of nervous breakdown because they just don't have any more serotonin to give after a while. Ketamine is another one that there are ketamine use disorders that have been reported. I think the kind of distinction here is like, why are you approaching this drug and what are you hoping to get out of it? You know, when they do studies of ketamine-assisted therapy or MDMA-assisted therapy, nobody ends up addicted to the substances or even misusing the substances in this type of context, because everyone's just coming and trying to heal themselves.
Right.
You know, of course, if you put them in a more of an open-ended and recreational kind of container, you get different types of intentions of people using, and you know, kind of less diligent thought perhaps about the pattern of use or the dose and things like that. And you know, can someone get MDMA use disorder or ketamine use disorder? Sure, they can. But, you know, is it something to be really scared about compared to opiates, amphetamines, cocaine? No, not really.
Now, ketamine is a dissociative, is that correct?
Well, I mean, you'll read about it as a dissociative anesthetic, yes,
Mm-hmm.
and it's like why it was originally put on the market.
Mm-hmm.
You have, you know, other articles of, you know, ketamine-assisted psychotherapy that are detailing people having, you know, classic ego death, rebirth types of mystical experiences with ketamine. So there's this kind of semantic debate about, well, is ketamine a psychedelic? Is ketamine a dissociative anesthetic? I mean, is ketamine an antidepressant? Is ketamine an analgesic? The answer is yes, all of the above.
Mm-hmm.
And I've kind of, I just let people have whatever they want to call it, you know, is what it is to them. It works for me, as long as you're not calling it like a psychotomimetic hallucinogen. I mean, even that has its validity as far as like neuroscientific model and of illness and psychosis and things like that. Absolutely. But, you know, I think if you're just talking to a patient about therapeutic use and you're calling it a psychotomimetic, it just kind of, that seems a bit outdated.
Right. Now, ketamine is, I guess there must be two different enantiomers of ketamine that are available, because it seems like there's a street ketamine that's highly effective and highly dissociative, and there's a medical grade ketamine that you can get from a pharmacy that doesn't really have any of those properties.
Well, you're right. There's R and S ketamine. This basically, drugs are like this. It's really interesting is that they kind of come in right and left-hand versions of each other. You know, the same way that you have two hands that look identical, but you know, if you try to put a right-handed glove on both of them, it doesn't fit both of them. It only fits the right hand, right? Mm-hmm. So ketamine is like this. There's R ketamine and S ketamine, and the ketamine that was used medically forever, and the one that is probably available on the street, is racemic ketamine, meaning that it has both R and S ketamine. So it has both the left and the right hand version to it. The one that was medically approved is S ketamine. And, you know, as far as differences, this is an area of kind of ongoing research and debate. S-ketamine certainly is dissociative, though, and it certainly can deliver a lot, if not identical, effects as far as psychedelic properties or dissociative effects compared to racemic ketamine. I just kind of think it comes down to dose and route of administration. Kind of racemic ketamine, I guess intranasally is the most common kind of recreational route of administration. But, you know, what is the dose that the people are using? And, you know, are they using several administrations of ketamine to kind of, titrate or kind of allow themselves to go deeper and deeper versus kind of this one-shot nasal spray that, it's supposed to take you to a non-linear or a non-ordinary state of consciousness, but I don't think that the dosing is meant to take you to a K-hole, which probably would be the intention of many recreational experiences.
Interesting. So it's an issue of dosing.
Dosing and route of administration, because certainly like the original ketamine studies, they did intravenous, and I mean, yeah, all of that gets in. A lot of psychiatrists are using intramuscular injections because it's just a little bit less invasive. You don't have to insert an IV line. There's less kind of monitoring that you have to do, less infectious risk with an intramuscular injection. And again, that one is, I mean, almost all of it gets in. You're talking about nasal. I mean, now you're talking about, well, I mean, not as much as absorbed nasally as intravenous or intramuscular. You know, not all of it is even absorbed through the nasal mucosa. You get a drip, goes down the back of your throat, and now you're talking about oral absorption. Oral absorption of ketamine is really low. It's about 16, 17% of what would be intravenous. Intranasal is somewhere between 40 and 60%. So if you're using ketamine intranasally, you're probably getting, you know, on a milligram by milligram basis, you know, kind of around 40% of the dose that you would be getting if you use that same amount intramuscular or intravenously. So, yeah, unless you're stacking administrations or using really high doses intranasally, it's going to be a less intense experience. So,
Interesting.
You know, there may very well be something to different pharmacological differences in the isomers and the subjective experiences that they give people, but I think that the differences that you kind of hear about out there at the moment are could reasonably explain purely with dose and route of administration.
Interesting. Okay. I feel like we can talk forever. The subject is so fascinating and interesting. So it's been absolutely lovely speaking with you. I guess one area that I did want to touch upon, and there's so many different areas, but one of them was that issue of people obtaining psychedelics or particularly ayahuasca off the black market and doing it by themselves. What are your thoughts about that?
Well, I mean, obviously, as a Martin Luther King had a quote, and the quote was, I'm going to hopefully get it right, but it might be kind of paraphrasing here. And his quote was that an unjust law is not a law to be followed, it's a law to be changed. Mm-hmm. So as a pharmacist, I can't really recommend that you break the law, which, you know, if you're ordering plants that contain DMT off the internet to your home and you live in the United States, you know, that would be an illegal act. So there's that. Let's just say you're not deterred by your warnings and or you already kind of ordered it. Well, you know, in this case, I kind of feel that it probably shouldn't be your first rodeo, to be honest. I think that ayahuasca is the type of psychedelic that, I mean, if you're taking other medicines, you should either be an expert in those medicines or have them kind of, you know, screened by someone for contraindications with ayahuasca. Ayahuasca, too, is often done as this kind of ritual, or shamanic ritual, and there's something to be said for that. I mean, you'll meet people that are kind of like, yeah, you can be your own shaman, you just order it and brew it, and you do this and that. I kind of feel that people tend to get out of their experiences what they put into them. Mm-hmm. So, for example, if you are you know, in contact with a facilitator, shaman, retreat center, and they're telling you have to wean off these things and eat these foods for this long ahead of time, and you know you've got to spend some money to participate in the retreat, and you've got to travel somewhere. Obviously, that's a big deal, and you know when you invest that money, you have to travel. You know, you've been making yourself halfway miserable because you've been avoiding all this sugar and coffee and all the things that normally help you get through the day ahead of time. You know, you are ready for change. You're kind of a little emotionally raw already, and you're very, very invested. Mm-hmm. Whereas, you know, maybe if you're kind of like, oh, I'm not sure about this psychedelic thing. You know, I don't really want to spend $500 or $600. Maybe I'll just order it off the internet and kind of brew it up and give it a try, and that way I'll know if it works. And if it works, then maybe I'll invest some more later. I feel like this type of approach to the work sort of shortchanges you. And I am first and foremost a cognitive libertarian, so I'm not here to say that like you should not drink ayahuasca at home. That is, highly dangerous, and no, I don't think that's the truth either. I just think that formal structure and intention really make a difference when you're approaching the work for healing, and people should kind of follow that, and that's exactly why these ritual things and lineages are set up to hold the container, to hold the space, to give yourself permission to really go deep. Whereas, if you're by yourself and you're worried and there's no one supervising, and, are you going to feel that comfortable to go that deep? For some people, the answers might be yes, because they're experienced and they know what they're doing. And for other people, it might be like, oh, heck no, I really should have a facilitator.
Interesting. Now, obviously, ayahuasca is under a lot of, research and scrutiny, and so is psilocybin. What about peyote or San Pedro or other, mescaline type derivatives?
Yeah, so that one is just interesting, right? I've almost wanted to write a blog that's kind of like says something like psychedelics left behind, or too long for the therapist, or something like that, because it's kind of like, LSD is a little more demonized or stigmatized compared to maybe something like psilocybin, maybe. Something like mescaline, why are we not using more mescaline in the clinic? And I can think of a couple of reasons. I think one of them is that, first of all, the issue with peyote and cultural appropriation is huge and should not be ignored, in that, when Westerners colonized the United States, there was essentially a genocide of Native Americans, and we stripped them of their land, which was their identity and spirituality, and stuffed them all in this, reservation in Oklahoma. And they fought the federal government for a couple decades before, the federal government kind of said, okay, well, we took absolutely everything from you, so I guess we'll let you eat peyote. That's like the one thing that we'll kind of give you and allow you to do. So for, us now 100 years later to say, oh, just kidding, peyote is actually our medicine to treat, the depression and alcoholism and whatever else that our society has kind of created for itself, it does not sit well with Native Americans, or really me even. I'm not a Native American. Then it becomes a question of like, what about just synthetic grade mescaline? What about San Pedro? What about trichoceros? There's a bunch of cacti that produce mescaline. It's not just Lophophora williamsi or peyote. So, could we use that? And then I get a little bit more perplexed as to why there's not more research going on with mescaline. And really the biggest kind of thing I can think of is that, a mescaline experience, a full-blown one is 12 to 18 hours. And, what are we going to have, shifts of therapists that they see the first 8 hours and they tag team with someone else? It's sort of like, I think that the kind of 4 to 6 hour experience with MDMA, psilocybin, or ayahuasca just kind of fits into our model of psychedelic therapy better than LSD or mescaline does, because their durations of, can you really expect a therapist to be alert and support someone through a 12 to 18 hour experience? And probably, there's definitely San Pedro shamans or facilitators that are present the entire time and help people through, but maybe as far as the resources it takes to put together a clinical trial and things like that, we just, haven't quite got around to it. maybe that's part of the reason too, is just thinking about your patients, subjects, or participants, and that, well, gosh, this is an experimental thing right now, and of course we all know it works because it's been working for thousands of years. But they're just studying it in a clinical study now, and trying to reassert that it works, and so they're doing it with they want to cross every T, dot every I, create, basically overkill atmosphere of safety, if there is such a thing. Putting someone through I guess if you have a difficult psilocybin experience, it's really only 4 to 6 hours of difficulty, but maybe if you have a difficult LSD or mescaline experience, it would be 8 to 10 hours. So there's maybe more, I don't know, maybe it's just difficult to get it past an ethics review board. I'm not sure.
Right. Okay.
I don't know.
Makes sense.
But yeah, it's been a mystery to me. It's sort of like, well, mescaline is the classic prototype phenethylamine psychedelic.
Mm-hmm.
Why is there no interest in using it? I don't know. It's not because it doesn't work.
That's interesting.
Yeah.
Well, I think we have just scratched the surface with psychedelics, and I feel that we need to have a deep dive conversation at a future point and really talk about these individual psychedelics and how they really do treat many different conditions.
Yeah, it's been
Sorry.
I was just saying it's been a pleasure chatting, and if you ever felt like having me back for maybe a more exactly deep dive or focused talk into a specific substance or illness, then I'd be more than happy.
I think that would be fantastic. Well, and thank you so much for all the information that you shared. I think a huge part of getting the word out and educating is that people are safe and they know what they're putting in their bodies. And I think you did a great job of really informing people both on the psychedelic and psychotropic part. So I really appreciate you for doing that.
Yeah, thank you. And always in these podcasts or conversation, there's inevitably like some type of loose end that doesn't quite get wrapped up. So again, my website is spiritpharmacist.com. If anyone wants to contact me because they have questions that were sparked from this interview. Fantastic.
Well, thank you so much, and we will speak soon then.
Yeah, take care. Thank you again.
Bye-bye now.